Good afternoon, everyone. My name is Abiola Adewusi, and amongst a lot of things, I am the second vice president of the Association for Fertility and Reproductive Health. I am also the LOC chairperson for the 2025 conference that is coming up in Lagos this year. In addition to that, I also participate actively in the training committee of the AFRH. So I have been in the background supporting our wonderful speakers and moderators over the months. And I have to say that I'm very, very proud and happy to be part of this amazing team. Today, joining me is our wonderful Dr. Bangbopa. Everybody knows him. If you have anything to do with AFRH and you don't know Dr. Bangbopa, you are on your own because he has been the one holding forth and making sure that all these programs goes well and alive whenever we're having our webinars. Today, we're going to be talking about gonadotropins regulations, secretions, and mechanisms of actions. So I'm going to just quickly stop here and hand over to Dr. Bangbopa, who is my co-moderator today, to give us a few insights and information about what we should be expecting in the next few minutes and in the nearest future. Thank you.
So thank you, Biola. So good evening, ladies and gentlemen. We would like to, along with my colleague, welcome you to this to the webinar for this month, the FRH scientific webinar. As we do today is going to be another wonderful day. We have an excellent resource person with us here who will be introduced later. I'd just like to make a few announcements so we can be reminded that the 15th annual International Conference of the AFRH is coming up in Lagos in September. And so I'd like to remind us that we to register if you haven't registered. And let us also inform our friends and our colleagues to also register. Registration for doctors is it's 200,000 for non-doctors, 150,000, and for OBGYN residents, 50,000. And for non-members, that is 250,000 naira for doctors, 200,000 naira for non-doctors, and 100,000 naira for non-member OBGYN residents. Secondly, I would also like to remind participants in this year's conference that the deadline for call for abstracts will end on the 31st of July 2025. That is Thursday next week. Please let us remember to submit our abstracts. The abstracts are specifically for two of the sub-themes. Sub-theme one is cutting edge approaches to ART practice for Nigerian innovation, shaping the future of fertility care. And the second one is optimizing success in ART, advances in embryology, endometrial receptivity, and implantation. Like I said, the deadline for submission is July 31st, 2025. That is next week, Thursday. We have just about 8 days to go. And I also like to remind our members and our attendants that you can always please join us and follow AFRH on our social media platforms. We have AFRH Nigeria on Instagram, AFRH Nigeria on Facebook, LinkedIn, AFRH, and we also have AFRH Nigeria on X, and those social media handles are on the screen right now. I also like to remind us of the rules of this webinar series. Remember, anyway, everybody is muted until you are allowed to speak. But sometimes the algorithm might not work well, and you might be released. So please let's just keep our mics muted so that we can give the presenter a full opportunity and a quiet environment to make his presentation. And let us remember that during the lecture, we will not entertain questions until afterwards, and the questions will be taken in the Q&A box. So please, if you have any questions while the presenter is making presentation, please endeavor to type them in the Q&A box. That's from where we will choose questions for the presenter to answer after the presentation. So essentially that is all. Please remember, like I said, let us register for the conference that is coming up in September. Let us remember to submit our abstracts, and please follow AFRH on our social media platforms. So thank you very much and you're welcome. Mrs. Adewusi, please, can you take over?
Thank you very much, Dr. Bangbopa, for doing what you know how to do best. Thank you very much for that introduction and the housekeeping rules. I would like to quickly go on to introduce Dr. Onuh at this time. Dr. Sunday Omale Onuh is a fellow of the West African College of Surgeons and a fellow of the National Postgraduate Medical College of Obstetrician and Gynecology, and he's a fellow of the International College of Surgeons. He is a faculty and resource person to many postgraduate training institutes. He has authored and co-authored several original and reviewed articles in both local and international peer-reviewed journals, several chapters in reputable scientific textbooks in obstetrics and gynecology. He is also a reviewer to many scientific journals. He is a member of various professional bodies, both locally and internationally. Dr. Onuh was a former medical director at NISA Premier Hospital, Abuja, and he is presently the chief consultant, obstetrician and gynecologist, lead fertility specialist, and lead endoscopic surgeon and medical director at the famous Dada Hospital in Abuja, Nigeria. Please join me to welcome our speaker for today to discuss the topic of gonadotropins, regulations, secretions, and mechanisms of action. Over to you, Dr. Onuh.
Thank you very much, Mr. Adeosi, my able second vice president. And it's a great privilege to be here with AFRH on this series of webinar. I've been a keen participant and listening to very, very interesting topics that have been coming up. I say a very big thank you to the training committee. It's a very, very wonderful thing you people are doing, and with all our support. Today, I happen to be on the other side today to talk about gonadotropins. You know, we're going into reproductive endocrinology and physiology too, away from the conventional talk on fertility for topics. I hope in the few time we have, I'll be able to, you know, share a little of what I know in this field. By way of outline, we'll go through the introduction. We talk about the secretions and regulation of the gonadotropins. Then we'll talk about the mechanism of actions and their actions. And we'll now quickly look at the synthetic forms and their role in control ovarian hyperstimulation. Just a little tip there, and we can conclude. By way of introduction, you know, FSH, that's the follicle stimulating hormone and the luteinizing hormone are the main gonadotropins, you know, in fertility practice, secreted from the anterior pituitary gland. You know, when we're talking about gonadotropins, of course, there's one other one, which is the human chorionic gonadotropins, you know, but that's not the core of our topic for today. And looking at the gonadotropins, there's one thing that is common to them. You know, they are composed of two chains, which is the alpha subunit and the beta subunit. And practically, most of these gonadotropins, they have similar alpha subunits, which has 92 amino acids and are virtually identical in both FSH and LH. That's the follicle stimulating hormone and the luteinizing hormone. They have similar upper subunits, but where the difference comes is in their beta subunits. And the secretion of FSH and LH is in the anterior pituitary gland underlies a neuroendocrine control of the hypothalamic pituitary gonadal axis. It has to, there's a connect from the higher center, which is the hypothalamus, to the pituitary and the target organs. And depending on the level of maturity of the follicles and on the phase of the menstrual cycle, LH and FSH regulate steroidogenesis in the theca and the granulosa cells of the ovary. Then when we look at the FSH, the beta subunit has a 111, that's 111 amino acids, and a sugar portion, which is covalently bonded with asparagine and composed of the N-acetylamine, N-acetyl glucosamine, and the galactose. So all these are what are there, which are bonded, um, in a pattern. Then we look at the luteinizing hormone, which has 120 amino acids in its beta subunit, compared to, the 111 in the follicle stimulating hormone. Luteinizing hormone is essential for estradiol synthesis and follicular development, as well as we have the follicle stimulating hormone acting for maturation. It is known that a minimum amount of luteinizing hormone secretion is necessary in order to allow stimulation with follicles FSH to succeed. And that is the basis for which the synthetic form try to play around the natural pattern, what is called the two-cell gonadotropin theory. Looking at their secretions, secretions is very, very, it's a complex mechanism, and we try to do the simplified form. Regular ovulatory cycle is achieved through precise functional and temporal integration of the hypothalamic pituitary gonadal axis. The different component determines the hormone secretion, starting from the hypothalamus, the pituitary, then before we get to the gonads. And one thing, when we're looking at the higher center, there's a pulsatile release of gonadotropin releasing hormone, that's the GnRH, from the hypothalamus, which stimulates the pituitary, to produce or secrete FSH and LH. This is usually done in a pulsatile fashion, not continuous like we find in other hormones. And it's on this basis that a lot of modulations, have brought into play to bring about neuroendocrine management of some condition like adenomyosis, endometriosis, and even uterine fibroid, to bring about persistent downregulation of the higher center. The two gonadotropin hormones have distinct but highly integrated function within the ovary, which we are going to see shortly. This is a semantic presentation of the regulations, starting from the higher center, the hypothalamic center, acting on the pituitary center, and the two main gonadotropins that are coming from there, the LH and FSH, hitting on the ovary. And the action on the ovary, will evolve into steroidogenesis, which eventually have some feedbacks, to the hypothalamus and the pituitary. So we'll look at it in this way. Steroid regulates gonadotropin secretion during the different phases of women's cycle via a complex system of positive and negative feedbacks in parallel with follicular development. Estradiol is the most important regulator of the hypothalamic pituitary gonadal axis. That's one thing that we need to know. That estradiol is the main steroid that is involved with the regulation. Even though we have other steroids playing a role, then the gonadotropin surge attenuated factor is also an important element. A non-steroidal ovarian substance, that attenuates the endogenous LH surge in superovulated women. And that even happened in the natural cycle. And this is what actually initiates the positive feedback that allows for LH surge in the natural cycle. Now we'll look at the feedback mechanism that is involved with this. In the early follicular phase, we have an increase in follicle stimulating hormone level that triggers estradiol secretion. And the consequent secretion of estradiol selectively inhibits FSH release, needed for the selection of the dominant follicle. This is a negative feedback phase. And this maintains rapid GnRH positivity during the late follicular phase. Then we now have the gonadotropin stimulating activation factor that maintains the pituitary in a state of low responsiveness to GnRH. So this brings about a good feedback that we see in the early follicular phase. But now in the late follicular phase, we have accelerated GnRH positivity that causes an increase in the luteinizing hormone level, which further stimulates estradiol secretion, formulating in a positive estradiol feedback to produce the mid-cycle surge of the luteinizing hormone. And that is what eventually culminates into ovulation. If there's a marked decline in the gonadotropin stimulating activation factor, but bioactivity that facilitated the onset and the full expression of the surge of the LH surge that eventually leads to ovulation. Then in the late follicular, in the luteal phase, initially early follicular phase, the late follicular phase, then we'll now go into the luteal phase. The luteinization of the ruptured follicle results in progesterone secretion, which reduces the frequency of GnRH positivity. And there are also some theories of a little of estrogen amidase progestational changes, the slight rise of progesterone just prior to ovulation, before the steep rise and maintenance that causes the maintenance of the luteal phase. Now, with the demise of the corpus luteum, the level of estradiol and progesterone and in the age sharply decrease, and the GnRH pulse frequency and FSH secretion gradually start to increase to begin the next cycle. So this goes on in a cyclical fashion, to bring about the regulation of the female menstrual cycle. So we can see this in a semantic representation of the various dynamics that happens with the levels of the follicle stimulating hormone there indicated here, and that of the LH, getting to this point. And when you see, if you match it with the estradiol, you see that at the surge, increased level of estradiol at this level causes a positive feedback that leads to the LH peak on this other level. And it eventually hitting the ovary, that's the gonad, to cause ovulation and all the sequence of the events that happen thereafter. Let's look at the actions, and mechanisms of which these actions, comes to play. The role of LH and FSH in follicular development and ovulation cannot be overemphasized because they are the main factors. FSH is involved in granulosa cell proliferation, intrafollicular development, while LH receptor and LH receptor expression and estrogen synthesis. It is key to note that FSH has a big role to play in the expression of the LH receptor. Luteinizing hormone promotes androgen production by the Theta cells, while FSH induces aromatase activity and thus the use of androgen as a substrate for estrogen biosynthesis. LH-related increase in intraovarian androgens has been postulated to enhance the sensitivity of the granulosa cells to FSH. In the early follicular phase of the menstrual cycle, the initial increase in FSH stimulates follicular recruitment and later maturation. In granulosa cells, LH enhances FSH action by increasing estrogen production, which leads to increased secretion of LH to produce the mid-cycle surge. The LH surge triggers oocyte maturation and ovulation. LH sustains the survival of the corpus luteum and regulates growth and stimulates the expression of cytokines involved in embryo development. Now, in terms of the mechanisms in which this thing acts, LH actually acts via receptors. LH binds to a glycoprotein coupled receptor activating adenylate cyclase. While the adenylate cyclase, an enzyme, then produces the cyclic AMP, thus increasing its intracellular concentration and activating the kinase molecules called the protein kinase A, that's the pKa. pKa then phosphorylates specific intracellular protein that subsequently achieves the end physiological action of LH, like steroid production and ovulation ovulation trigger, as it were. So if we look at, the synergy, there's a great synergy between FSH and LH, in the serogenic pathway, according to, depending on the phases of the menstrual cycle. In early follicular phase, we see in response to LH, the Theta cell converts cholesterol to androgens. Cholesterol is the main precursor of the steroids. So the androgen enter the granulosa layer to be converted to estrogen via FSH-induced aromatization. And serogenic events are mainly regulated through the cyclic AMP and the protein kinase A pathway, just as we mentioned earlier. These events are, events that happens in the Theta, at the Theta cell level. Then when you get to the granulosa cell, most often in the late follicular phase, we have the FSH-induced LH receptor formation on the granulosa cell. And in granulosa cell, LH enhances FSH action by increasing estrogen production. So we have a chain of events happening, and all are actually interdependent and interwoven, and they happen in synergy. Expression levels of FSH and LH receptors in granulosa cell at different developmental stages have also been studied, and the follicle stimulating hormone receptor expression in the granulosa cell is induced by androgen that were derived from growth differentiation factor 9 stimulated Theta cells. In the Theta cells, luteinizing hormone receptors expression is noted from their appearance in early follicular phase, while in the granulosa cell, follicle stimulating hormone stimulation is essential for luteinizing hormone receptor expression. However, FSH alone is not sufficient to respond to the luteinizing hormone surge for oocyte maturation, ovulation, and subsequent luteinization. To achieve this stage, various local factors are derived from the granulosa and the theta cell in response to FSH and LH stimulation have to work synergistically in an autocrine paracrine manner to strongly induce the LH receptor expression. Following the LH surge, the LH receptor expression decreased markedly. The messenger RNAs are involved in the transient LH receptor downregulation. Following ovulation, LH expression drastically increased again towards luteinization, and this event continue in cycle. Now, we'll look at the other form of gonadotropin, which is the HCG. That's the human chorionic gonadotropin. The main source of production is the placenta in pregnancy, which is produced mainly by the syncytial cells in pregnant women. And it is known that HCG is also produced in a very small quantity in the pituitary. And HCG has LH activity. You know, there's a biosimilarity between these two gonadotropins. You know, the alpha subunit, same thing, 92 amino acid, but here we have the beta subunit comprising of 145 amino acid, you know, and we have 8 glycosylation sites with a weight of, total weight of 39 kilodalton. Now, I want us to look at, sources of production of human chorionic gonadotropin. The main source, of course, is the placenta. We have the basic HCG and the hyperglycated HCG. But the pituitary HCG is the sulfate HCG, and it's slightly have some, slight difference from the placenta HCG in that it has reduced half-life and faster clearance in vivo, and decreased receptor binding and in vitro activity versus that of the placenta HCG. So when we're talking of HCG, main production site is the placenta, not the pituitary. Just that it is what to know that there's some level of activity of HCG production at the pituitary. Let's look at the relationship of these gonadotropins in fertility management. What that takes us to synthetic gonadotropins. We've had different previous webinars that have dwelled mainly on control ovarian hyperstimulation, different protocols, and different agents and different gonadotropins in use. So we're just making highlights in this presentation. The synthetic form of HCG came into use many years ago. We have the urinary HCG, then the highly purified urinary HMG, which is either highly purified gonadotropins, urinary, which comes in form of HMG, or pure FSH. The highly purified urinary FSH is actually manufactured by the use of monoclonal antibody specific to FSH. That's the technique, and the importance of purification is just to reduce the level of impurities as much as possible, and this enhances its action when we administer for control ovarian hyperstimulation. Then we also have the recombinant technique, which has been in existence since the late 1990s. And, recombinant preparation of FSH and LH are produced by inverting the genes encoding for the alpha and beta subunits into expression vectors, which are transfected into Chinese hamster ovary cell lines. So there are a lot of technology goes into this to bring about the recombinant gonadotropins. And in the onset, the recombinant gonadotropin available was just recombinant FSH, But of late, companies have moved on to, producing recombinant HMG, as it were, to simulate the natural pattern that have a combination of FSH and NH, working in synergy to bring about follicular recruitment and maturation, and eventually the process of quality and effective ovulation. The recombinant technology is safer and better as far as impurities and the risk of contaminants are really concerned. So in control ovarian hyperstimulation, we make use of this recombinant technology. We make use of the technology of the use of FSH and LH in stimulating the ovary, or stimulating the ovary to produce reasonable and quality eggs, that we can actually now fertilize and eventually transfer the resulting embryo. Gonadotropins, as we know, they are the hallmark of controlled ovarian hyperstimulation, even though a lot of other protocols have come into play, like people using a natural cycle, low dose, or the clomid or letrozole cycle without the use of gonadotropin. However, world over, the use of gonadotropin is actually the hallmark of controlled ovarian hyperstimulation. And it is based on simulation of natural release, but in a highly controlled fashion and patient-tailored manner that the synthetic gonadotropin are used. Safety is actually the key when we talk about the use of synthetic gonadotropin. I want to briefly conclude on this journey by saying that FSH and LH are both essential for folliculogenesis. FSH and LH stimulates gonadal secretion of the sex steroids from the ovaries, which in turn regulate the feedback loop that controls the gonadotropin releasing hormone positivity, hence gonadotropin production. In the fertile cells, the luteinizing hormone drives the production of androgen, which are converted into estrogen via the aromatase enzyme, aromatization process. While in the granulosa cell, the synergistic action of FSH and LH increase estrogen synthesis and stimulate follicular growth. Synthetic FSH and LH are made in such a way to mimic endogenous form, but with better efficacy and administered in a controlled fashion. The future of LH and FSH use in artificial reproductive technology is coming in the form of FSH LH receptor polymorphism, which is actually out of context of today's talk, which when completely, dealt with, when the research is ongoing, when that comes, because we try to use that as a marker of ovarian reserve, which may come out better than the present AMA that we're using. When that comes, science is moving. That's why I like the H-ray dictum. Science moving people, people moving science. So it's a continuum. And when that comes, we'll have better use and better achievement of the knowledge of the natural cycle in doing our artificial or controlled ovarian cycle. Thank you very much, and God bless you.
Thank you very much, Dr. Onuh. Please, a round of a round of digital applause for our speaker. Please, if you can. So, thank you, Dr. Onuh, for such a wonderful presentation. I mean, for those of us who know you, we're not disappointed at all. I mean, we didn't expect anything less, and indeed, we're not disappointed. Thank you for such a concise overview of what gonadotropins are, how they are regulated, how they are secreted, and the mechanism of action. I do not have any question in the Q&A box first, so I'm going to ask you the first one. You've alluded a bit to it, but I'd like you to just put some flesh on it. There's a popular saying that art imitates nature, or is it that nature imitates art? So we can actually use that art in this case. Art is ART, imitates nature. You have told us the way. You've shown us the way in art we try to imitate nature in these compounds that we use for simulation. But how does it relate in regulation itself? Is there any difference between the way the exogenous products that we use are regulated compared to the way it is done in nature? So while you're answering that, I'm sure if there are other questions, please put your question in the Q&A box. Thank you. Prof, please.
Yeah, thank you, Dr. Bamboka. The regulation, yes, there are different protocols comes into play when we're talking of ART now. Trying to mimic nature. The standard launch protocol, for instance, in artificial reproductive technology, make use of the fact that the pituitary responds to the hypothalamus in a pulsatile fashion. So when the generate agonist is used in a continuous fashion, it maintains the negative feedback and completely desensitize the pituitary. That way, the pituitary does not send any signal endogenously to the ovary to allow whatever we're giving exogenously, that's either the FSH or the HMG, to act without the fear of premature luteinization, because there's no feedback to the pituitary any longer. Pituitary goes quiet, so it's not going to respond to any signal that is coming from the ovary, because the ovary is already, quiescent in terms of feedback. So our stimulation process, goes unhindered, unless otherwise we on our own are now stubborn. We do not pick the sign of oocyte maturation and continue to stimulate. Of course, when the follicle gets tired, it will ovulate, whether you induce ovulation or not. If you continue to whip it with medications. Now, the short protocol, the antagonist protocol, also use the same vein, but in a very slightly different manner, because there is an initial synergy between the natural cycle and the exogenous stimulation that is coming. And all the aim of this is to make sure that there is no selectivity. Selecting a single follicle to gain dominance. You want as many follicles as possible to achieve dominance. So, you continue, but the key point is you do not want any premature luteinization. So you are in control of when you do your trigger, for you to be able to have as many oocytes as possible without losing any before the time of oocyte retrieval.
So thank you. If I understand you, that beyond ART imitating nature, ART actually in the process of control ovarian stimulation, we actually seek to control and modify nature in a way to achieve our aims. If I understand you very well.
Exactly.
Thank you. Thank you so much. I'm going to check the question box. You see, the problem when an expert gives a presentation is that nobody will have questions.
Mm.
I hope it is not that Dr. Onuh has spoken above the head of all of us. But I would like to say, oh, there's a question now. Oh, it's in the chat box. So let me go to the chat box. Okay. So the question comes from, I don't know who the person, whoever DO is, please forgive me. In regards to IVF, how does the choice of gonadotropin protocol impact oocyte quality and embryo development? Once again, in regards to IVF, how does the choice of gonadotropin protocol impact oocyte quality and embryo development? Please let's remember to put our questions in the Q&A box, not the chat box, but we'll take them anyway.
The name is Deborah Odega. That's her name.
Deborah Odega, please forgive me. Such beautiful names, both Deborah and Odega. Thank you for your question. Dr. Onuh.
All right. Okay. Yeah. The choice of gonadotropins, how does it impact on embryo quality and egg quality and embryo quality? Actually, when we're talking about choice of gonadotropin to be used and impact, it's been a topic of debate. And based on this, I mean, there was a working committee of ASRM and actually, no, I think the ASRM working committee that that some years ago to look at different protocols, different gonadotropins, and outcome as it were. But a lot of the submission, the recommendation, there was a lot of controversy actually. But the recommendation came to say that look, choice is actually operator dependent. However, safety was just the key. Based on safety, based on safety, the protocol choice now, not the gonadotropin choice. Protocol choice was tilted towards the antagonist protocol based on safety. Now, choosing gonadotropin, was more of a difficult thing because there was sometimes you cannot completely divulge industrial interplay. I mean, one industry tries to apply the other one, but what is there as a baseline, individualizing your protocol is key. There are some patients that you will want to use pure FSH. There are some patients that you want to use HMG. But a lot of meta-analysis comparing use of pure FSH, use of recombinant this, results came out to say, look, there's really no significant difference in whichever HMG agent you use. Even though, in some studies, there were some advantage, so to say, but statistically, there was not really a serious difference. However, there's some recent study that showed that if you have people with reduced ovarian reserve, or poor responders, so to say, that when you use recombinant HMG, that it tends to, give advantage in terms of number of oocyte and quality of the oocyte that is coming, but research still ongoing because recombinant HMG is relatively new. When I say relatively, of course, it has been there for some time, but world over, relatively new, and a lot of research are still going on. So until such a large population is subject to research and have meta-analysis of different studies, different papers. We cannot just say exactly, but few papers that come out are in support of using recombinant FSH, recombinant HMG for poor responders or people with diminished ovarian reserve in terms of giving them a better advantage. But by and large, choice of gonadotropins to be used is actually operator dependent and patient tailored in most cases.
Thank you, Doc. So I should add that Deborah also requested that if it will be possible to receive a soft copy of your presentation. I'm sure that Biola will speak to that later, especially if Dr. Onuh does not have any objections. So the next question that we have in the question Q&A box is from an anonymous attendee. And the question is, are there lifestyle practices in the patient that can jeopardize oocyte stimulation when using synthetic gonadotropin protocols? Once again, are there lifestyle practices in the patient that can jeopardize oocyte stimulation with synthetic gonadotropins? Please take it.
Okay. Okay. Yes. I mean, we answer. There are lifestyle practices that generally that jeopardizes fertility and stimulation, gonadotropin stimulation. When we're using synthetic gonadotropin, our aim is also to achieve fertility, to achieve quality eggs and quality embryos for transfer. So it is known that when heavy smokers, heavy alcoholics, all this affects air quality, whether spontaneous natural cycle or stimulated cycle. However, one thing I want to point out to is uh, those life practices do not really, do not cross react with the agent, with the gonadotropins to cause any toxic effect in the system. That's not what I'm saying. However, they affect the outcome of that the quality of the oocyte itself, whether it is stimulated cycle or natural cycle. Then we also talk about um, weight, which has been a controversy, where there's morbid obesity and I mean when there's excess weight, this also have a way of affecting ART practice, ART outcome, even though it's been a little bit on the controversial side. But we know that where there's too much weight, we have a lot of androgens, that you can now can aromatization, giving excess estradiol, and when there's estradiol in excess in the system, I mean all these have a negative impact in fertility as a whole. Dr. Bambopa, are you there
Thank
with
you.
me?
I'm here. So the
Maybe
next
let me hear your opinion too on this.
Okay,
Because it's an
so
interactive session. Yeah.
what I can say about that is that in terms of some of those things, especially external agents like smoking, like alcohol, if they have, because some of them they will have an effect on the body system generally, and they may not affect the gonadotropins, systemic gonadotropins themselves, but they may affect the metabolism of these agents in the body. And we use them by dosing them in different ways. So I mean, for example, if you take alcohol and alcohol increases liver metabolism and increases general metabolism, that might have an effect on the availability of the drugs. I mean, what I mean is that it will affect maybe the final pharmacodynamics of the agents that we're using. So one has to consider that. Of course, the effect of some of these agents also on free radicals in the body, and we know, of course, there have been issues, controversies about the effect of free radicals in the body when the body is undergoing the process of ARC. So these things, and that's why a lot of experts will suggest that look during the period that you need to actually avoid a lot of these external toxins, try to ensure that the body is as clean as possible. So I believe that that's another way that these things, that these agents or these lifestyle preferences can have an lifestyle modifications can have an effect on stimulation, even when we're using synthetic agents, as it will also do if we're using natural agents. So the next question is from Emmanuel Koroji, and he says that, is there any preference for each age group as regards to the use of gonadotropins? That is, does the age group affect the use of gonadotropins? Go on, sir. Dr. Onuh, did you hear? Is our lecturer still with us? I hope you're not. Dr. Onuh,
But
can you hear me?
agent is, yeah, I can hear you.
Okay, please go ahead. Did you hear the question?
Yes, I had a question. I said, can you hear me now?
I can hear
Am
you.
I
We can
loud?
hear you. We can hear you. Please
Okay.
go on.
Okay. I said that in terms of the gonadotropin formulation with preference with age, no, because it's dosaging that actually has age concern. For the younger ones with normal endocrine function, we use much lower dose compared to the older ones. Then where age now comes is when we now get to the above 39, naturally at that point there's a low reserve. Reserve start going down and the rest of them. So when we have low ovarian reserve situation, some experts are beginning to think that, okay, some gonadotropins might do better than others. But all these are still subject of scientific research and debate. So the bottom line is the dose of gonadotropins varies with age. It's not one dose for all. Two, another thing that will also affect the dose is the ovarian reserve. When you have people with polycystic ovarian syndrome with a very high AMH level, even at advanced age, you want to use a lower dose because they have a tendency of responding or over responding. So you don't want to use age specific dose recommendation for such people. So that's why we keep talking about patient tailored uh, stimulation protocol rather than using a bracket a one size fits all.
Yeah, so no one size fits all. We have to do our patient-centered, specific patient-centered stimulatory protocols plans. So thank you, Dr. Ono. I think we're getting to the end of this, and it's been a very interesting presentation. So once again, before we go, I'd like to just before I hand over to my co-moderator to give the vote of thanks and also end. I'd like to remind us again of the announcements we made earlier. Please, registration for AFRH is still ongoing. Um, so let's ensure that we register. Also to remind us that the deadline for the submission of abstract is next week, 31st of July. Please let's ensure that we submit our abstracts before the closure of the deadline. And also would like to remind you that to join us on our social media platforms, whether it's on Instagram, Facebook, LinkedIn, Twitter, or even WhatsApp. So please join us. So I'd like to hand over to Mrs. Bella Adeosi to please help us to thank our presenter for today and also close the webinar. Thank you.
Thank you very much, Dr. Bangbapa. Dr. Onuh, my personal person, thank you for doing justice to the topic. And of course, for some of us that have been in the space for a long time, even though we're not doctors, we know how this thing works. It's a good refresher course for us. And I'm sure for the new ones, it's a good eye opener for them. So thank you very much for coming on today. taking time out of your busy schedule to give us this very lucid presentation today. And to our listeners, our attendees, thank you very much for taking time out to making this webinar a huge success. I think the last count I had was 40, and that's pretty big. I mean, this is not discussions on surrogacy where, we have an overload of people attending. Taking time out during, the week to come to this webinar is actually very, very significant. So we thank you all. Greetings from AFRH. So having said that, we're going to draw the curtains for today's webinar, and we look forward to having you next time. One more thing, as far as the soft copy of the presentation, I know that we may not be able to share it because we're trying to put all this information together to form an AFRH textbook eventually. But what will be available is the recorded webinar. It's going to be shared on our YouTube page. So please feel free to go there and listen to this webinar at your convenience. Thank you very much, everyone, and have a wonderful evening.